Welcome back to the deep dive. You know, we spend a lot of time on this show talking about the future.
We do.
We talk about breakthroughs, AI, new protocols, this idea that tomorrow is always going to be smarter than yesterday. It's the standard narrative of human progress, right?
Agree.
We learn something, we apply it, and things get better.
It's the narrative we all want to believe in, especially in medicine. You just assume that if you walk into a doctor's office in 2024, the care you get is objectively better than what you would have gotten in 2008.
Exactly. You expect the arrow to point up. But today we are looking at a story where the arrow points down.
Way down.
And not just a little bit. We're looking at a massive systemic regression in how we treat the single most common killer in the world.
It really is a bit of a ghost story. It's a mystery about a solution that we had in our hands, a treatment that was proven, effective, widely adopted, and then for reasons that are honestly baffling, the medical system just kind of stopped doing it.
And we aren't talking about some obscure tropical disease here. We're talking about high blood pressure.
Hypertension, the silent killer.
The thing that half the adults listening to this probably need to worry about.
And the scale of the data we are looking at today it's immense. This isn't a small survey. We are doing a deep dive into a massive serial cross-sectional study from Kaiser Permanente, Southern California.
Let's just pause on the scope of this for a second, because usually medical studies are like, we look at 500 people for 6 months.
Right. This is different. This data set covers the periods from 2008 all the way to 2024.
16 years.
16 years of data. And it tracks 221,384 patients.
Over 220,000 people.
These are people newly initiating therapy. So, nearly 250,000 people walking into a clinic, getting a diagnosis of high blood pressure, and starting their treatment journey.
So purely from a data perspective, this is gold. This is effectively a census of a mid-sized city over a decade and a half. When we see a trend here, it's not a blip. It's not a statistical error.
Exactly. It gives us incredibly high confidence. And the mission for this deep dive is to figure out why a healthcare system that was doing everything right in 2011 decided, consciously or unconsciously, to stop doing it by 2024.
And more importantly, what that actually did to the health of those 200,000 people.
Right.
So let's introduce the protagonist of our story, or maybe the victim, depending on how you look at it. We are talking about initial combination antihypertensive therapy.
A mouthful, I know.
It sounds incredibly technical, but let's strip away the jargon. What are we actually talking about here?
It's actually a very simple concept. Initial just means right at the start.
Day one.
Combination means more than one. So essentially, it means starting a patient on 2 blood pressure medications at the same time, right from the get-go.
Okay. And the alternative, the old school way.
That's monotherapy. Start with 1 pill. You tell the patient, come back in 3 months. You check the blood pressure. If it's still high, maybe you increase the dose.
Another 3 months?
You wait another 3 months. Maybe then you add a second pill. It's a slow, stepwise, reactive process.
I've heard a great analogy for this. Monotherapy is like showing up to a house fire with a garden hose.
That's a good one.
You spray it for a while, and if the fire doesn't go out, you walk back to the truck to get a bucket.
That's a very vivid way to put it, but it's accurate. Combination therapy is calling the fire department immediately. You show up with the hoses, the foam, the ladder truck. You attack the problem from multiple angles, instantly.
And scientifically, why is that better? I mean, isn't taking fewer pills generally better? Why hit the body with 2 things at once?
Because the body is smart. It fights back. Blood pressure is regulated by this complex network, your fluid volume, how tight your blood vessels are, hormones, kidney function.
Right.
If you block just one of those pathways with one drug, the body often compensates by just ramping up the other pathways.
So it's like a game of whack-a-mole. You hit one mechanism down, and another one pops up to keep the pressure high.
Precisely. By using 2 drugs that work on different mechanisms, you are blocking the escape route, so you prevent that compensation. It's much more effective at actually lowering the pressure.
And just to be clear for the listener, this isn't some fringe experimental idea. This isn't, biohacking.
Not at all. Kaiser Permanente, the health system in this study, actually adopted this combination-first approach way back in 2005. It is the recommended guideline. Major heart associations recommend it. The evidence has been there for a long time.
So we have the setting, Kaiser Permanente, 2005. They say, okay, the science says start with 2 drugs, let's do it. And for a while, it seemed like it was working perfectly.
We call this the golden era of the study, from 2008 to 2011.
Paint the picture for us. What was happening?
It was a success story. In 2008, usage of initial combination therapy was at 39%. So roughly 4 out of 10 new patients were starting on 2 drugs immediately.
And that number kept climbing.
It did. Doctors were listening. The system was working. By 2011, usage peaked at 45%.
Almost half.
Almost half of all new patients were getting the aggressive, guideline-recommended treatment.
And you mentioned there's a P trend involved here. For the non-statisticians listening, that's basically a measure of, is this real or is this just luck? Right.
Correct. The P trend for that increase was 0.009. In the world of statistics, that's a very solid signal. It means this growth wasn't an accident. It was a concerted, successful effort to improve care. The trend line was pointing up.
So if I'm a hospital administrator in 2011, I'm popping champagne, we have a protocol, doctors are following it, adoption is growing, we are fixing hypertension.
You would think so. But this is where the mystery novel aspect kicks in. Because 2011 wasn't the start of a plateau. It was the peak.
This is the twist. Because usually, if a tech company has a feature that works, adoption goes to 80–90%. But here
the chart falls off a cliff. After that peak in 2011, the trend didn't just flatten. It crashed.
How bad of a crash are we talking about?
It is stark. We went from that 45% high in 2011, and usage plummeted to 27% by 2024.
Wait, let me process that. We went from nearly half of patients getting the best treatment to basically 1 in 4.
Exactly. And the P trend for this decline is less than 0.0001. That is a statistician's way of screaming. It means this wasn't just random noise or a bad month. This was a 13-year structural regression.
That is absolutely baffling. I mean, usually when usage of a drug drops like that, it's because something bad happened. Did we find out it causes a terrible side effect? Did the guidelines change?
No, and that's the paradox. The guidelines didn't change. The evidence didn't change. In fact, during this exact time period, the evidence got stronger that combination therapy was superior.
So the science got better, but the practice got worse.
The practice on the ground marched in the complete opposite direction of the evidence. It's like if we invented the seatbelt, usage went up to 45%, proved it saved lives, and then suddenly everyone just stopped wearing them.
Okay, I want to play devil's advocate here. I'm trying to get inside the heads of these doctors. Is it possible that they just got smarter? Maybe they realized, hey, for mild blood pressure, 2 drugs is overkill. Let's save the big guns for the people who are really sick.
That is a very logical hypothesis.
Yeah.
It's called clinical discretion.
Right. You don't bring the fire brigade to put out a candle. Maybe they were just refining who got the treatment.
The researchers thought of that. So they broke the data down into 4 tiers of blood pressure severity to check exactly that hypothesis.
Okay, let's walk through these tiers, because I have a feeling this is where my optimistic theory falls apart.
It does, unfortunately.
Oh, okay.
Let's start with tier 1. This is systolic blood pressure between 130 and 139. So elevated, but not a crisis.
Okay, what happened there?
Usage dropped from 33% to 20%.
Okay, a significant drop, but maybe that's the candle scenario. What about tier 2? That's 140 to 149.
Dropped from 42% to 22%.
Oof, basically cut in half.
Yep.
Tier 3. Now we are getting into dangerous territory, 150 to 159.
Dropped from 49% to 29%.
Okay, so even in the serious cases, usage is tanking. But what about tier 4? These are the people with blood pressure over 160. These are the walking time bombs. These are the people where, if you don't treat them aggressively, they are at massive risk of stroke. Surely doctors kept hitting these cases hard.
This is the most shocking statistic in the entire report. For these highest risk patients, tier 4 usage dropped from 61% to 36%.
Wow. From 61% to 36%.
Just think about that. In 2011, if you walked in with severe hypertension, you had a solid majority chance, better than a coin flip, of getting the gold standard care. Today, you're in the minority. You are more likely to get the garden hose treatment even though your house is blazing.
So the argument that doctors were just being more selective is completely dead in the water.
Completely. The system didn't become more selective. It became more passive. Across the board, regardless of how sick the patient was, we just stopped doing the thing we knew worked.
Why? I know the study is observational, so it can't read minds, but do we have any clue? Is it cost? Is it laziness?
It's likely a mix of factors, but the big suspect is something called therapeutic inertia.
Therapeutic inertia. Break that down for me.
It's the path of least resistance. It is easier to write 1 prescription than 2. It feels safer to start slow, even if the data says it's not. It takes less time to explain 1 pill to a patient than to explain why they need 2 pills immediately.
So it's human nature.
It is. Systems naturally drift toward entropy. Unless there is constant pressure alerts, performance reviews, education to keep the standard high, people drift back to old habits. and the old habit is monotherapy.
That is frustrating, but it brings us to the big so what question. We know they stopped using it, but does it actually make a difference? I mean, maybe monotherapy, the one pill approach, is actually good enough.
That is the crucial question. If the destination is the same, who cares if we take the slow road or the fast road? But the study looked at that. They compare the efficacy.
And what did the scorecard look like?
They looked at the likelihood of achieving target blood pressure between 6 and 12 months after starting treatment. They use a metric called the prevalence ratio, or PR.
Okay, for those of us who skipped stats class, remind us what a prevalence ratio tells us.
It just compares the success rate. If the ratio is 1, there is no difference. If it's higher than 1, the combination therapy is better.
Got it. So for the standard target getting blood pressure below a 140/90, how did combination therapy do?
The PR was 1.09.
1.09.
Right. So combination therapy was about 9% more likely to get patients to that standard goal.
Okay, 9% is good. It's statistically significant. But if I'm a busy doctor, 9% might not feel like enough of a reason to overhaul my entire workflow.
That's a fair point. But here is the catch. 140/90 is the old definition of success. We know now, thanks to recent major trials like SPRINT, that getting blood pressure lower below 130/80 provides significantly better protection against heart attacks, strokes, and death.
Right. The lower target is the real goal for optimal health. We don't just want, okay, we want safe.
Exactly. So for that strict target less than 130/80, the prevalence ratio wasn't 1.09, it was 1.31.
Whoa. 1.31.
Yes. That means you are 31% more likely to hit that optimal health target if you start with combination therapy.
That is a massive difference in medicine. Usually we are fighting for 2 or 3% improvements. A 31% advantage is huge.
It is profound. It basically says that monotherapy has a ceiling. It's okay at getting you to, not terrible, but it is significantly worse at getting you to healthy. If you want to get a patient to a truly safe blood pressure level, starting with 2 drugs is vastly superior.
And I imagine a lot of that goes back to that inertia you mentioned. If you start on one pill and your blood pressure goes down a little bit, everyone just kind of says, good enough.
Right.
You never get around to adding that second pill.
Precisely. We call it getting stuck. You start with 1, you get partial results, and you stay there. Starting with 2 pills bypasses that entire failure point. You are baking the success into the initial decision.
So let's synthesize this. We've established 3 things. 1, combination therapy was used heavily in 2011. 2, we stopped using it. 3, it works way better than what we replaced it with.
Correct. All 3.
So if you put those 3 things together, the conclusion should be obvious. If we stopped doing the thing that works, people's health must have suffered.
And that is exactly what the data shows. This is the real-world consequence segment of our deep dive. We can actually trace the decline in health outcomes that matches the decline in therapy usage.
Let's look at the control rates, the percentages of patients who actually managed to get their blood pressure under control.
In 2011, our peak year for usage, 75% of patients hit the standard target of 14/90.
3/4 of all patients, that's a solid number.
Very solid.
What about in 2024?
It dropped to 66%.
So almost a 10% drop in general success.
Yes. But again, look at the strip control,
Yeah.
the 13/80 target. This is where the real damage is visible.
This is the one where combination therapy had that 31% advantage.
Exactly. In 2011, 35% of patients managed to hit that strict target. In 2024, only 25% did.
Only 1 in 4.
We lost 10 percentage points. That might not sound like a huge number in the abstract, but you have to remember the denominator. We are talking about hundreds of thousands of people.
Yeah.
That represents thousands of real human beings walking around with higher blood pressure and higher risk of stroke than they would have had if we were just doing what we did in 2011.
That is tragic. It's not like we're waiting for a new drug to be invented. We had the solution. We used the solution, and then we just forgot.
Forgot might be generous.
Yeah.
But it highlights the synthesis of this entire deep dive. We stopped doing the thing that worked, initial combination therapy, and as a direct result, fewer people have their blood pressure under control today than they did 13 years ago.
It's a sobering realization. You always want to believe that the medical system is a machine that constantly optimizes itself. But this proves that regression is possible.
It forces us to confront the reality that medical progress isn't a straight line. It requires maintenance. It requires vigilance.
So let's bring this home. This deep dive has been a journey from a peak to a valley.
To recap the narrative arc, Kaiser Permanente implemented a winning strategy. It peaked in 2011 with high usage and high success rates. Then, usage inexplicably slid backward for 13 years, and it dragged the success rates down with it.
The study's conclusion is pretty blunt about this, isn't it?
It is. They state clearly that initial combination therapy is associated with improved control. And they emphasize that this decline underscores a critical need to support guideline concordant care.
Guideline concordant care. That's fancy talk for do what the instructions say.
Basically, it's a call to action for healthcare systems. It's not enough to just write the guidelines or publish the papers. You have to actively ensure they are being followed.
Because if you don't,
If you don't, gravity takes over. The system drifts back to the path of least resistance, prescribing one pill and hoping for the best. And as we've seen, hoping for the best leaves 10% of your patients behind.
it really makes you think about the gap between knowing the right thing to do and actually doing it.
That's the big takeaway for me. We often think the challenge in medicine is discovery finding the cure. But this deep dive shows that maintaining the discipline to use the cure is just as hard. We have the data. The prevalence ratio of 1.31 is staring us in the face. Yet, the system drifted.
It's a provocative thought to leave with our listener. It suggests that having the cure or the protocol isn't enough. You have to have the will to execute it every single day for every single patient.
It raises an uncomfortable question. What else are we doing less effectively today than we were 10 years ago simply because we lost focus?
A reminder that progress isn't guaranteed. It has to be protected. Thanks for joining us on this deep dive.
My pleasure.
We'll catch you on the next one.
Take care of yourselves and maybe check your blood pressure.
Can't hurt.
See you next time.